Okay, well, so far I've been talking to you about theory mostly and how it seems to agree with a lot of observations. Now I want to go on and talk about the clinical study we did where we actually did some measurements on these patients to see if this theory matched their situation and whether the treatment actually helped them. So that's what we're going to talk about now. And this study was done in a private practice, Dr. Neil Nathan. At that time, he was in Springfield, Missouri. He's since moved to California, so he's in the San Francisco area now, Santa Rosa. Dr. Nathan was one of the first MDs who took me seriously, okay? So he's my hero. So I want to tell you about his book here, okay? It's called On Hope and Healing for Those Who Have Fallen Through the Medical Cracks, okay? And that's available on Amazon, Neil Nathan, okay? It's a good book, You'll testify it's a good book, right? Yeah, okay. Okay. So anyway, we got a little money from a private donor who wants to remain anonymous, and with that we were able to pay for the lab test. And so we had informed consent. People, we explained to them what the whole situation was, and they agreed to it. The treatment ran for 6 months. However, we added some more time at the end where we did individualized treatment. So for 6 months, we treated them all the same. But after 6 months, we added some things to individuals depending on their situation to see if we could help them a little more. And then on the outcome measures, we used the methylation pathways panel that I showed you before. And then we also had the people rate their own symptoms. Now, this is sort of subjective. We didn't use actimeters to see how active they were, or sleep studies to see how well they could sleep, or neuropsychological tests to see how well their brain worked. If we had more money and more time, we would have done that kind of thing, but we just had them rate their own symptoms. So this is not the world's best study here, but we did what we could. Oh, there's Neil Nathan and myself. So we had 30 women in this study, and all of them had had fatigue for a long time. And then when we actually studied them with our strict criteria, 21 of those 30, we said, okay, you have real chronic fatigue syndrome according to the definition. Now, maybe they all had it, but we were trying to do it by the book here. So we used the Fukuda criteria, and then plus we insisted that all of them have post-exertional fatigue and malaise, okay? That's kind of the hallmark symptom now of chronic fatigue syndrome according to a lot of people. So we said, okay, you satisfy the standard CDC definition, plus you must have this, okay? And then we did a statistical analysis after 6 months of treatment. It happened that of those 21 people, 18 also satisfied the rheumatologist criteria for fibromyalgia. So they had both chronic fatigue syndrome and fibromyalgia. They're all women, Caucasian. We had a range. We had one lady who was 84 years old, okay? And the average age was 52. And they've been sick, some of them for more than 20 years, one for only 1 year. And these are patients that Dr. Nathan had been treating for a long time in his practice. So he knew these people very well, and he had tried everything else that he knew of on them, okay? So for treatment ranging from 1 to 12 years, he had done adrenal treatment, thyroid treatment, sex hormones, food allergies, dysbiosis of the intestine, mercury, heavy metal toxicity, infections, Lyme disease, mycoplasma, mold, magnesium deficiency, and nutritional imbalances. He tried everything, okay, everything he knew of, and he still had people who were sick. And then he heard about methylation, and he said, I'm going to try that on these people. And he did, and then that's what this study ended up doing. Well, these women also had other diagnoses, okay? 15 of them had migraines. 13 had irritable bowel syndrome, and so on. You can see the various things they had. So in addition to chronic fatigue syndrome and most of them fibromyalgia, they also had all of these things. Okay. So this is the protocol we used, and this is an earlier version of what I showed you before. I showed you the simplified treatment approach. This is an earlier version. It's essentially the same thing, but, we used this form of hydroxycobalamin, which is a sublingual lozenge, and again, 2 milligrams or 2,000 micrograms. We use Folapro, which is a methyl tetrahydrofolate, and 200 micrograms. And then we use this one here. Now, this one here, that's a product of Metagenics. So is that. Those are both Metagenics products. But Metagenics changed the formulation of this one without changing the name, which was not a very good idea in my opinion. But anyway, that's what they did. So it took me a while to find out that the stuff wasn't the same anymore. So that's why I changed to actifolate, and then later on I went to folinic acid. So the more recent one is I'm just using folinic acid. Over time, I got less and less happy with folic acid, and there was a little bit of folic acid in this one. Right, let's see, here it is. Well, folic acid has some problems, and so, you know, I decided to try to minimize that and go for the more active forms of folate.
What is the difference between folinic acid and folic acid?
Well, folic acid is an oxidized form that has a long shelf life, and commercially it's a nice product to have on your shelf in the drugstore or whatever. So folic acid is the common form used in supplements, okay? And that's also the form that some countries, like the US, add to grain and wheat products and so on in order to try to help with the birth defects for, you know, neural tube defects, spina bifida, and that sort of thing. And I would say most people are able to utilize folic acid and convert it into the forms that the body can really use. But unfortunately, there are people who can't do that very well. And it requires 2 reactions with the enzyme DHFR, which is dihydrofolate reductase. And the folic acid has to react with that in 2 reactions to get to tetrahydrofolate, which is the reduced form that the body can now use to make methylfolate, or the kind that makes, you know, the ATP, or the one that metabolizes histidine and so on. All of those can come from that. But that step is very slow. It's a slow step, and people vary by a factor of 5 in their ability, in the rate of that reaction. So a lot of people, if they take folic acid, it just ends up floating around in their bloodstream, you know, and there's some evidence that there's a higher risk of cancer. There's some evidence that the natural killer cells are suppressed by folic acid in the bloodstream. So I just decided, you know, let's get rid of folic acid and go with the active ones, because they're available over the counter, they're not that expensive, and the body can utilize them right away. Now, folinic acid, that's the same as the drug called leucovorin. They use leucovorin as part of cancer treatment sometime to stimulate the folate. It's not a chemotherapy drug. It's used to help with chemotherapy. So it's been sold for many years as leucovorin, but it's available over the counter as folinic acid, and it's a reduced form of folate, so you don't have to go through that reaction sequence I was talking about, and most people can convert that readily into other forms of folate and use it. So in the body, it's sort of a buffer. It doesn't have a purpose of its own, but it can be converted and used for other forms. So it sort of stores folate in the body. Okay. Okay. So then we have this vitamin formula, and I'll show you the composition of that here in a minute. And then the phosphatidylserine complex, and we talked about that before. Here's the vitamin. And it's a lot of words there, but you know, it's got the vitamins, it's got the minerals, and then as you move down here, you'll see some extra things here. Okay, here's broccoli, broccoli powder, citrus bioflavonoids, antioxidant. There's some choline, inositol, well, some of the PABA. There's some garlic, methionine, milk thistle, that's for the liver, NAC, N-acetylcysteine. Here's pine bark extract, another antioxidant, taurine, turmeric, which helps to make glutathione, stimulates the glutathione production, intrinsic factor, trimethylglycine or betaine, nucleotides, that helps support DNA and RNA formation. Carnitine, that helps with the fat metabolism. So you see there's just a few extra things in there. And like I say, sometimes people will say, well, you know, milk thistle, I can't handle milk thistle, so that's that. You know, I can't take that. So, okay. But if you're not, you know, sensitive to any of that stuff, it's a very good supplement. Okay, then we had the people count their symptoms from a list of symptoms. Just tell me today, check which one of these you have. And we just counted up how many they had at 0 time, and then at 6 months we did that again. And then we also had outcome measures, and they were asked to rate them 1 to 10, okay? 1 to 10, how good is your energy, your sleep, your mental clarity, your freedom from pain, and your overall feeling of well-being, whatever that is, okay? So these are rather subjective things. And the problem with this kind of thing is when somebody starts to get better, they forget how bad they were before. Have you ever seen that happen? And so when they rate it now, they don't rate it quite as high as you might think they should because you knew how sick they were before, but their scale has shifted, you know. They're now ready to be well, and they're considering, oh, this is normal, you know, and so that's the problem with this kind of thing. But nevertheless, we did it. And then we also asked them about their percentage of improvement, and again, very subjective. So this was a symptom checklist that we gave them, and we got this from Dr. Richie Shoemaker, and there are 2 pages here. I'll show you the other ones, but these are the kind of symptoms that Richie Shoemaker finds in people with biotoxin illness, you know, mold illness. But, you know, they're also found in chronic fatigue syndrome in general. I mean, these are the kind of symptoms you see. So, so we used his checklist, and this was the rest of it. So you can see there are a range of things involving different body systems and so on. So we just asked the people to check the ones you have, and we'll count them up. Oh, what happened there? Oh, maybe that's the end of that file. Here, let's try another one. If I can figure out how to do that. Yeah, okay, here we go. All right, so how did it come out? Well, various patients said things got worse at first, okay, and they had symptoms. In most cases, then things improved after that. 3 patients decreased their dosage to every, what happened there? I don't know, I'm going to have somebody else operate this for me, I guess. Okay, here we are. They couldn't take it every day. It was just too intense. So they had to drop back and take it every 2nd or 3rd day and then work up so they could take the full dosage. Why do they have these symptoms? Well, I think there are 2 things that happen. One is when you first stimulate the methylation cycle, more of the homocysteine goes to methionine, and there's less available to go down to glutathione at first. So you actually lower glutathione when you first start this. That's not a good thing to do. So sometimes I have them add liposomal glutathione or acetylglutathione, something like that, to try to boost the glutathione initially, because otherwise they get into excitotoxicity and it's not a lot of fun. The other thing is, a little later, what happens is you stimulate the sulfur metabolism, you start to raise glutathione, and that gets the detox system and the immune system working again. Well, those systems are now facing a big backlog of toxins and pathogens that have accumulated while the person has been sick. If they've been sick for 20 years, they've been storing this stuff up because they couldn't get rid of it. Now all of a sudden you've got a detox system working, an immune system working, and you start to kill those bugs and mobilize toxins, and those toxins float around in the blood. They expose all the cells, and the cells respond. You have symptoms. So it takes a while to get them to excrete in the stools or the sweat or the urine, get them out of the body. Sometimes we have them take activated charcoal or lemon juice or both, and that will help to move the toxins out, bind them in the gut, and move more out through the kidneys. But there are other things you can do. Some people use clay if you have metals. But I think activated charcoal has been the best one that people have told me anyway. So anyway, at first they feel worse. And if they don't feel worse at first, it's probably not working, okay? And so it takes a little coaching. You have to tell them, okay, hang in there. You're going to be okay, you know. Just go a little slower and you'll do it, you know. And Dr. Nathan was very good at that. He was able to keep all these people on these supplements. Oh, yeah, okay. Okay, then, what did I do now? I can't reverse it. Oh, you got it now. Okay. I don't know. All right.
That's right.
Okay, thank you. Okay, so 16 out of the 30, over half, said it got worse at first. And most of those cases, it happened within 3 or 4 days, it started getting worse. But then, in some cases, it took as long as 2 weeks. Most of the symptoms weren't too bad, and none of them quit, okay, during the first 3 months. We didn't have any dropouts in the first 3 months. The most common side effects were gut problems, pain, cramps, constipation, diarrhea, 6 out of 30, 20%. Some had pain, 4 out of 30. An increase in fatigue, 3 out of 30. And other symptoms, decrease in appetite, poor sleep, weak legs, flu-like symptoms, increase in anxiety and depression. So had a variety of symptoms, but they weren't fun. You know, people said, is this really going to work? You know, and you have to say, yeah, hang in there. And then, so for those who did experience improvement, the average time was about 5.6 weeks, okay? So you have to get them through this first part in order to see the benefit. If they quit early, they think, oh, it didn't work, you know, it was no good. Well, you didn't hang in there, you know? So sometimes you got improvement right away, and sometimes it took 8 weeks before you got improvement. The average was 5.6. So at 3 months, all 30 of them stayed in the study. 25 of them reported improvement. And among the group that reported improvement, 8 of them reported marked improvement, whatever that is. Okay, that was kind of in the judgment of Dr. Nathan in talking to them. He said, okay, you've had marked improvement. So that's really good, whatever that is. You can see this is not as quantitative as it might be, but it's what we were able to do. Okay, what about at 6 months? Well, all but one of them went to 6 months. Now, we had one dropout, and that was kind of unfortunate. This lady had 100% relief of pain, 60% overall improvement, but her family wanted her to go to the Mayo Clinic, okay? So she pulled out, and I don't know whatever happened to her, but we were doing great before she quit. 2 patients reported they were completely relieved of pain, complete relief of symptoms, and they went back to work full time, okay, and decided not to continue. I'm well, I don't need this treatment anymore, goodbye, you know, so they were fine. One patient had a hip replacement, and she couldn't come back. And then there was one patient who was disappointed, and she said, I've had it, that's it, I quit. So, you know, but that's not a bad record to get 29 out of 30 for 6 months. Okay, after 6 months, Dr. Nathan continued the methylation supplementation and then added individual treatments based on measuring their polymorphisms, genomics, the visual contrast test. Now, this is Dr. Shoemaker's test to see if they have neurotoxins in the brain. It's an eye test with a chart, and you measure their ability to see contrast between black and white. And then evidence of heavy metal toxicity. He did a urine, a chelator provoked urine test to see if they had heavy metals, and then also mold toxicity, and that was based mostly on exposure. You know, do you know whether you have mold in your house? And
What is mold?
mold, you know, you got the Swedish word for that? Yeah. Okay. So anyway, 25 out of 30 got through 9 months. Now, here's the data. This is the glutathione, and this is 0 time before we started treating. This is the reference value, the lab reference for normal people, healthy people. This is what it's supposed to be. This is where they were. You can okay, well, there's quite a bit of spread in this data, but notice that, sure enough, they do have glutathione depletion. one of the main parts of the hypothesis is glutathione is depleted. Well, sure enough, it's low. It's supposed to be up here, it's down here. And then notice that it rose with time. Well, I don't know. It doesn't want to go backwards. How do I do that? I'm sorry. I must have done something wrong again.
Front and back.
Oh, this is forward and backwards? Okay. Oh, good. Okay. Oh. I still haven't found the one I want here. Let me keep trying. Okay, here. All right, finally understand it. Okay, so glutathione was low, and as we treated the methylation cycle, it went up, and you can see it went to normal. Now, we didn't give these people glutathione. We didn't give them any, okay? We fixed the methylation cycle, and glutathione just rose by itself. So that's the same thing that happened in autism, and we saw the same thing here. So that really tells you that those two are connected. If you can fix that one and that one comes up, there's a connection there, okay? And that's argument for this vicious circle that I've been talking about. Okay, now here's oxidized glutathione, and you can see it's supposed to be down there, and these people were high. And there's also a huge spread. You see, there's a lot of variation in these people. It tightened up a little bit as we treated. You can see the standard deviation decreased. And the oxidized glutathione went up. Now, that's not what we wanted. We wanted it to go down, but it went up. So there's still some oxidative stress mechanism going on in these people that's causing glutathione to be oxidized and not pumped back to reduce glutathione. What is that? It probably varies from one person to another. Now, we learned a little bit more about that as we went on. Okay, now here's the ratio between the reduced and the oxidized. And here's where it's supposed to be. Well, you can see we did improve it some, but we didn't get up there. And we would like to get up there. So why not? Well, partly it could be that we should have treated longer, but we didn't have the money to keep doing that. And I think some of the people are doing it on their own, but we didn't have the money to keep testing it, is what I mean. The other thing is, there's something causing oxidative stress, okay? And that's the thing I'll get to a little later. That's why the methylation treatment on its own is not the total answer for everybody. Now, I told you that we had some that went back to work full-time, they were fine. That's great, but most of them, that didn't happen. They got better, but not totally recovered. Okay, here's S-adenosyl methionine, and that's in the methylation cycle. Here's where it's supposed to be, here's where they were, and sure enough, it came up too. Now, we were working on boosting methionine synthase, which helps the methylation cycle to normalize. So this is a measure that did happen. We did improve the methylation cycle. Okay, here's S-adenosyl homocysteine, and that's the product of when S-adenosyl methionine gives away its methyl group, it becomes this. And again, we like that to be down here, but you know, it didn't go down, it went up a little bit. But then the ratio, here's the ratio, here's where we would like to be, and we actually made the ratio worse, okay? We like it to be up here, it went down a little bit.
Was that why they were worse in the beginning? Some of your patients were worse when you started the treatment.
Yeah, yeah.
Is that why?
I think it's a combination of glutathione depleting initially. Now, you see the first measurement point we have is at 3 months. And those effects that we were talking about happened before that, and we weren't measuring there. So I can't tell you for sure that glutathione went down, but I think it probably went down a little bit at first and then came back up. By 3 months, it was higher. So anyway, I'm not too sure, but definitely we would prefer to have you know, that come up to normal. All right, now here's a measure of the folate. This is 5-methyl tetrahydrofolate. And this is actually something we were giving. This was in the treatment. We were giving them 5-methyl. So you'd expect it to go up, and you know, sure enough, it does. But it still has a long way to go. That's the normal, you know. Okay, now this is a very interesting one. This probably is the best self-rating measure that we had, because this doesn't ask the person to compare to how they were before. This just says, today, how many symptoms do you have? Check them off. So you don't have to remember whether you were better or worse before. You just check how many. Well, you can see it dropped them in half. Is it 6 months? It almost dropped in half. So we really did get rid of a lot of symptoms, and I think that's the most reliable self-evaluation that we had. Now, I'll show you some other ones. This is where you had them rate 1 to 10 on the energy level. Well, they rated it better, you know, especially the first one, 3 months. Wow. But I suspect at this point they sort of thought, no, this is the way I'm supposed to be, and you know, if it didn't get much better, well, hey, you know. So I don't know. I mean, it's a judgment call, but at least it did go up. And if you do a statistical analysis of this, it is statistically significant. So that's good. This was sleep, the amount of sleep that they got, and they did get more, and it dropped back a little bit at 9 months. I don't know why, but anyway, it's still higher than it was at the beginning. So sleep improved. Mental clarity, and what is that, you know, how well you can think, and they evaluated that. Well, it got better. They felt like they were thinking better. And here was pain, and it rattled around a little bit, but it improved too, freedom from pain. So if those things are really improving, that's telling you that this treatment is affecting a lot of these different systems that, you know, body systems and organ. Yeah.
Question, real quick. How did you measure pain?
We asked them to. We didn't do an objective measure. We said, how's your pain compared to before? Okay, did it?
It's like, you know, VAS scale.
Yeah, that's right. That's what it is. Visual analog scale.
That's what you use.
Yeah, and it's very subjective, you know, it's very subjective. You know, we didn't do a dolorimeter or tender points, or we just,
But you used the VAS.
yeah.
Okay.
Mm-hmm. Okay, now this is sort of an interesting one. We measured some of their polymorphisms. We asked Dr. Yasko, if you only had a certain amount of money, which ones would you measure? And so she gave us, I think, 4 of them out of the 30 that she usually uses, okay? Which ones are the most important? We forced her to choose, okay? She really likes to do all 30, but we couldn't do all 30. So one of them that we did was this CBS, that's a cystathionine beta synthase. That's the first enzyme in the transsulfuration pathway, and that's where homocysteine goes down to where glutathione is. And we measured see whether those people had that one. Now that polymorphism, here we go. That polymorphism causes the enzyme to operate faster, okay? So if you have that polymorphism, it pulls sulfur metabolites, homocysteine, down into the transsulfuration pathway instead of leaving them up in the methylation cycle. Well, okay, here's I don't know if you can see that, but they're in sets of 3, okay? And I don't see the times on here. Oh, you can just barely read it. Well, these first 3 are 0 time, okay? Then it's 3 months, then 6 months, and then 9 months. And then that's the reference value there. Now, what we did was we added SAMI and SAH together. We just added those concentrations together. And the idea being that that's sort of a measure of the metabolites that are in the methylation cycle. Now, there are actually 4 in that cycle. There's those 2 plus methionine plus homocysteine, but we didn't have measures for those other 2. So we just added these 2 together. Okay, so okay, maybe that's a measure of how much is still in the methylation cycle. Well, sure enough, we found that if the person had even one of these polymorphism, now this is the heterozygous, that would be homozygous, 2 copies of it. So this is 1 copy, 2 copies. If they had even 1 copy, it really dropped that sum down. So that said that Amy Yasko was right about that if you do have that SNP, things drain out of the methylation cycle. And we saw that really does happen. Well, in her program, if she sees that, she says, aha, we have to add some more supplements, okay? So she has a little program to take care of that. We didn't do that. We just treated all these people the same, whether they had that or not, just to see, you know, what would happen. Well, as you can see, as time went on, it kind of tightened it up. okay? Even these people who had the SNPs, it kind of pulled them up, and here's normal, and you know, they're up to normal at 9 months. So it might work faster if you took account of that and treated it, but we didn't do that, and it still came up. So that you can evaluate that either way. You can say, well, it would have been better if you'd used the full YASCO treatment, or you can say, well, this treatment's good enough. You know, you can decide whatever you think about that. Okay, at 9 months, 15 of the 25 patients that remained reported they had experienced more than 50% improvement. That was their evaluation, whatever that means, 50% improvement. 3 of the 5 patients who dropped out had also reported 50% improvement. Okay, some of those went to work full time, for example. So if you add these together, 18 out of the 30, or 60%, reported more than 50% improvement. So that's not too bad. They're not totally well, most of them, but they're a lot better. After 9 months, we added an additional component, and this was something that Sid Baker, Dr. Baker, recommended to us based on his experience in autism. And he had found that if the person had high adenosine, that if you gave them some acyclovir, it would help that. So there were 9 people who still had that. So Dr. Nathan said, what about it? You want to try some acyclovir? And he said, what the heck, why not? You know, so they did. And this was the dosage. And 8 of those 9 patients reported an additional 20% improvement. Okay, so there you go. So now I have some, I think this is coming to the end here, I have some case studies, and these are written by Dr. Nathan, and these are people among those 30 women. He put these notes down for them. So, you know, when doctors tell you about case studies, they usually tell you about their successes, okay? That's normal, okay? We all would do that, right? But he's kind of honest. You'll see a failure here, too. So he kind of gave us some balance. This one is a success. So this lady, 49-year-old white female, 6-year history of fibro and ME. So her initial glutathione number was 3.0. This is the normal range. So you can see she's pretty low on the glutathione. And her SAMI level was 217, and you can see she's low there too. These are the main parameters we looked at, glutathione and SAMI. You get a pretty good idea what's going on from looking at those two. Well, she felt a little bit better after 3 months, but her glutathione was now 2.8, okay? It went down. And, but SAMI was at 226. It went up, okay? So after 6 months, well, glutathione started pulling up. You know, it's like a horse race here. Now glutathione starts contending here, and SAMI is 240. It came up further. She still didn't feel that much better clinically, okay? So she had a CBS polymorphism. That's the one I just showed you on that graph. And her 24-hour urine amino acids analysis showed elevated taurine and cysteine. Now that indicates that the things were running right down the transsulfuration pathway and producing taurine and cysteine, and particularly taurine, and it wasn't going to glutathione as well as it should. So she was given what Dr. Yasko calls her ammonia support formula. Okay, now Dr. Yasko makes up proprietary RNA formulations for different aspects, and she says these are the most powerful treatments that she has, but she doesn't talk about them too much publicly because she doesn't want the FDA to come after her, because they could say, well, you know, you're treating or whatever. But she has one called the ammonia support formula, and so when a person has this polymorphism, then she said, okay, you need to take this. And this stuff is not cheap, so a lot of people don't use it, but it apparently is pretty good. So so she did that, or she recommended that, and she was given that. She was also given nucleotides and trehalose. Now, nucleotides, those help to, I don't know. Okay. The nucleotides help to make RNA and DNA. And trehalose is a certain kind of sugar. It is found in certain insects and so on, and it has a variety of benefits. It can help to kill certain bacteria in the gut, and Dr. Yasko uses it as a filler. You know, in pills, you always have to have some kind of a filler if you're going to make a tablet. And a lot of times they use magnesium stearate. Well, she doesn't like that. So she uses trehalose, kind of glue things together, because trehalose does a lot of other good things for you. So she always recommends trehalose, you know. It's one of those wonderful things. But, you know, you have to, I'm not too sure what all the effects of it are. But anyway, that was done. And here she is, after just 1 month of these additional supplements, she felt so much better, she was able to resume full-time work, which she hasn't been able to do for 5 years, okay? So this is a great success. Free of pain, energy back to normal, and look at the glutathione, 4, okay? Right up there in the normal area. Sammy, look at that, 240, okay? Wonderful numbers. So this is a success. We like to see those, you know? All right, now let's look at the next one here. This is a very interesting case, too. This was the 84-year-old lady, okay? 2-year history of fibro and ME/CFS. Initial glutathione level was 2.7. You can see it's pretty low, lower than the other lady was. Sammy was 201. That's way low, too. So after 3 months, she wasn't any better. And then she had 2 episodes of a severe infection, and she was given antibiotics to control the infection. So at 3 months, her glutathione level was 3.2. That's somewhat better. Sammy level was 220, somewhat better. At 6 months, still no, she still didn't feel any better. Well, the numbers are looking a little better, but she doesn't feel better. Glutathione level was only 3. You can see that went down some. Her Sammy level had gone up a little more, 233. So she had a positive visual contrast sensitivity test based on the work of Dr. Shoemaker, and she was evaluated for heavy metal toxicity using this urine test provoked with DMPS, and they found high mercury. So she was treated with intravenous DMPS monthly and oral DMSA. So he gave her both chelators. She was also treated with cholestyramine. Now that's Richie Shoemaker's treatment for mold exposure. So Dr. Nathan just hit her with a kitchen sink. He gave her everything, okay? Now look what happened. By the completion of the study, she reported marked improvement, was able to join her friends for a week-long visit to Paris, okay, knowing she was pain-free, energy returned to almost normal. This is wonderful. 84-year-old lady, okay? So her numbers now are pretty good. Glutathione 4.0, Sammy 232. So, okay, now we have one that's not quite as happy a situation. This is a 55-year-old lady, fibro and ME for 8 years. She was receiving financial support from the Social Security Disability Insurance for those conditions. Now, in Sweden, I think this is a little easier to get. In the U.S., you have to fight hard to get this support. You have to go and convince a judge that you can't work, and that's not easy to do. Usually they turn you down. You got to get a lawyer. You got to try it again, and so on. So when somebody gets disability, that's a big deal. They celebrate. You know, they got some money coming in because they can't work. Okay, so Dr. Nathan had discovered an elevated level of mercury in this lady 4 years before we did this trial. But she decided not to do it for financial reasons, okay? She didn't want to treat it. Well, she did join this study, though, and her initial glutathione was 3.4, okay, still below the normal range. Her SAMI was 207, that was low. So over the study period, things came up. At 3 months, glutathione was 3.9. At 4.8 at 6 months, and 4.6 dropped a little at 9 months. But now it's in the range here. Sammy rose to 219, 230, and way up to 267 at 9 months. So these are pretty good numbers. Well, she reported a 20% improvement in energy, sleep, and well-being, but no additional improvements were noted. And she continued to decline to treat the elevated mercury level. So she wouldn't do it. And that was a disappointment to Dr. Nathan because he really thought that would pull her out of it, you know. But so I guess that's the end of the story. Oh no, we got some more here. Okay, yeah.
May I ask how many amalgam fillings had these women?
I do not know that. I don't know.
It's a pity.
Yeah. Maybe Dr. Nathan knows. I'll have to try to find out.
And when you didn't take these fillings away, you have no improvement.
Well, you know, that's another very interesting issue. I mean, you probably know that you have to be very careful about that. If you take the fillings out, sometimes the exposure to mercury vapor during that process makes the person a lot worse. So I think you guys know more about that than I do, but you have to be careful. So, but yeah, I don't know how many fillings she had. Okay, so this is sort of a summary here. We did see reduced glutathione levels. There was a partial methylation cycle block. The block was lifted by treating with B12 and folate together with nutritional support, especially looking at raising the activity of methionine synthase, which is the one we hypothesized to be partially blocked. So all of this is consistent with the hypothesis, okay? Treating to lift that block not only improved the methylation capacity, it also raised glutathione, as well as the ratio of reduced to oxidized, suggesting that these two phenomena are indeed linked in an interactive mechanism, as they also appear to be in autism. So this is arguing that, yes, there is a vicious circle that hooks these together, and you fix one, the other one comes up. And then why didn't all these patients get completely well? Okay, everybody, of course, wants to know that. I want to know that. Well, it wasn't enough. It wasn't enough to help most of them recover completely. And this is what I suggest is the problem. Stressors such as toxins and pathogens that cause the depletion of glutathione initially, and also there were some that accumulate during the illness after onset. So they not only bring on the disorder, but after the disorder happens and the detox and immune system are dysfunctional, then they accumulate even more, okay? So those things are building up, and some of those factors need to be treated specifically in addition to treating to lift the methylation cycle block. And also, we probably needed longer treatment than the 9 months that we gave. So another plug for Dr. Nathan's book, he talks about the other things that he does in addition to methylation in this book. And I think there's probably some validity to that. So, summary, we developed the hypothesis. Yeah.
Couldn't you, I don't know whether you covered this really, but you said that before drilling out feelings, you must raise
Well,
rather than doing afterwards.
well, that's
Here
my.
They drill out feelings and then people got sick and they continue being sick.
Yeah. Well, that's my opinion. And again, I think people here probably have more experience with this than I do. But I have heard from quite a few patients who, you know, they realized that the mercury amalgams were a problem. And, you know, sort of a general guidance in toxicology as well, get rid of the source of toxins, you know. So immediately people think, well, let's get those fillings out of there. And they go to the dentist and drill them all out of there today, you know, let's get rid of them. Well, that generally makes them more sick. And I think what happens is you heat the mercury and you raise the vapor pressure and they inhale that and they get a big exposure to mercury vapor and it makes it worse. Now,
You need selenium to also remove.
Exactly, yeah. Selenium will bind to mercury tightly, and in addition, I favor trying the methylation treatment first and trying to raise glutathione up in a natural way first, if you can. And yeah, selenium is very important too because it'll bind mercury, and then
Especially in certain parts in U.S. it's high in the Dakota area.
Yeah.
And so on, and it's low on the East Coast and West Coast.
yeah.
In Scandinavia it's low all the time.
Yeah, in Britain it is too. Interesting phenomenon that happened in the UK was when they joined what was called the common market in those days, they stopped buying their wheat from Canada and they started buying it from Central Europe, and you know, the selenium level in the whole population went low, and they started seeing Coxsackie virus, which, you know, is associated with low selenium. So.
And they can see that also in Finland if the wheat came from North America or if it came from Russia. It's the same effect.
Yeah, yeah.
Well, I made a study on a pilot study on patients with fibromyalgia many years ago, and I started to detoxify them by the concept of functional medicine. Jeffrey Bland, maybe you know him.
Yeah.
Anyhow, well, he has something called Ultra Clear.
Mm-hmm.
They were allowed to detoxify in 3 months, and then I took away the amalgams. Because in the functional medicine, they had found that they could keep the patients almost without symptoms as long as they were eating this Ultra Clear.
Mm-hmm.
When they stopped it, they got all the symptoms back.
Mm-hmm.
My patient got very, very, very much better by the detoxification. And then I took away the amalgams, and they never got the symptoms back, though they didn't continue with the
Ultra clear. That's
So
great.
I think the amalgams, it's a very important part of the treatment.
I do too. I do too.
And half of the patients didn't get the detoxification period. They got the amalgam removal directly.
Mm-hmm.
They never got as good as
Yeah.
the others.
Yeah.
So I think detoxification is very important.
I think you're right. Yeah. Yeah. I do think you have to do some things before you start drilling those things out. Yeah.
From the patient organization side, we always advise people we get in touch with to preferably start antioxidants and selenium
Yeah.
1 to 2 months before they start dental treatment.
Right.
Then since we don't trust most dentists except you, we advise people to take it very slowly, absolutely not more than 1 filling a month, unless they can get intravenous vitamin C, then you can go
Yeah.
faster.
Well, that makes a lot of sense to me. Yeah.
I forgot to tell you that half of the patients were quite healthy. They never more had symptoms.
Wow. Wow.
Follow them for 10 years.
That's wonderful. That's wonderful.
Where can you buy folate?
Okay. Well, there are several. You can buy it on the internet. I don't know about the situation in Sweden. Okay, but the cheapest one, methylfolate, is called Metafolin, and that one is it's the product made by Merck, and I think it's sold by Source Naturals. It may be sold by some other outfits too, but it's called Metafolin. And then folinic acid is also sold, and yeah, you can buy that from several suppliers, folinic acid. We just tell people to get it from Amy Yasko because she sells all of them, and that's holisticheal.com. But if you want a better price and you can shop around a little bit, you can get a better deal on some of them. But if you want to make it simple and you have the money, just order the whole works from Amy Yasko and you got it, you know. holisticheal.com. Okay, so anyway, the hypothesis has been developed, and it has this vicious circle mechanism, and these are the key features again. Glutathione goes down, B12 becomes functionally deficient, not absolutely deficient. If you measure serum B12, it looks fine. Sometimes it looks high, but the cells are not able to use it. It's functionally deficient. There's a chronic partial block of the methylation cycle, and then there's draining of the folate from the cells into the blood. And that's able to explain, I believe, well, the genetic predisposition is compatible with that, and most of the biochemical abnormalities and many of the symptoms that may seem unconnected to each other, they do fall out of this theory. Now, I do want to mention, though, that if the person has a serious infection or serious toxicity, those pathogens or those toxins are going to create their own symptoms, which will be on top of the core symptoms of chronic fatigue syndrome. So, you know, for example, if you've got a fever, you've got lymph nodes that are swelling, there's a pathogen in there, and that may have resulted from the fact that your immune system went down, so now you were vulnerable to the pathogen. So it's sort of tied to this mechanism, but the thing causing the symptoms is the pathogen in that case. You know, or Lyme disease. If you've got Lyme disease, you know, same thing. So I'm not saying that all the symptoms in this patient are directly tied to this vicious circle, but I'm saying the vicious circle can allow some of these other things to happen, toxins and pathogens, and then they can create some more symptoms on top of it. So lab testing is available, and again, commercial here, available from the gentleman over there. Scanned Lab supplies these things for Sweden, and the treatment with the methylation panel appears to apply to most patients, and I would say nearly all, but I haven't, you know, counted up everybody, but very rarely do I find one that looks normal in that panel. Yeah.
Do they have to go on with the treatment, or they can?
Oh, after that? Well, we don't have a lot of experience with that. Now, there are one or two people who send me an email once a year, you know, and they're totally recovered, they're working, and they say, hey, I just wanted to say hello, you know, and I'm still doing fine, and sometimes I take supplements, but I don't always remember, and, you know, so I don't have a lot of data on that. But my own opinion is, you know, if the person has a genetic predisposition, they are always predisposed. And if they are subjected to that load of stress again, I think they're vulnerable again. So I suggest that they try to support their B12, their folate, and some antioxidants. Maybe not the same doses here, but keep those up, you know, and then you have some protection. But I don't know what levels, and it may differ for one person to another, you know. But that's the only thing I can say about that. We just don't know enough about that yet. Okay. So there's several treatment protocols in use. All of them include folate together with high-dose B12. That's the key. It has to be together, those two together. We did do the clinical study, and with a simplified treatment, results were consistent with the hypothesis. I can't say it's proven, I can just say it's consistent, okay? To say something is proven to a scientist, look out, you know, you have to examine every possible alternative explanation and rule them all out, you know, and you gotta have a lot of money, time, and effort to do that. So I haven't done that, but it is consistent. It's producing significant benefits in most patients who use it, and it has resulted in apparently complete recovery in a small number of patients. I say apparently complete recovery because, you know, tomorrow they could pop back up on the internet and say, I'm sick again, you know. How do I know, you know? But so far, so good. Treatment has not been optimized. It's likely that it can be improved, and that's true. I mean, I just extracted something from Amy Yasko's panel, and I said, okay, try that, and it's been pretty successful. But you really, you know, if you're really going to be serious about this, you should do clinical trials and vary some things and find out what works better and so on. We haven't done that, you know, we haven't done that. And as I said, in most cases, it appears that other aspects, such as toxins and pathogens, must also be treated specifically to bring about complete recovery.
Excuse me, what kind of B12 do you suggest?
I favor hydroxycobalamin. Some people use methylcobalamin. Initially I was kind of reluctant. Now, Amy Yasko's position on that is she looks at some of the polymorphisms, and based on that, she decides which one would be the best for the person, okay? On the simplified treatment, I wanted to make it as simple as possible, so I had to pick one. So I said, well, I'll pick hydroxycobalamin, and that works for most of the people, but not for some of them. And particularly, you know, in order, the enzyme really needs methylcobalamin. That's the active form it really needs. So the person has to convert hydroxycobalamin into methylcobalamin. That requires glutathione and SAMe. And if they're very low in those things, they may not be able to do the conversion. So what I tell people now is try the hydroxycobalamin for 3 months. If you're not getting better, switch to methyl, okay? Now, the thing about methylcobalamin is if you take a fairly high dose of that and also a fairly high dose of methylfolate, what happens is you overdrive the methylation cycle. And that is not so good because then glutathione doesn't come up very well. So I think you have to watch the doses. Now, the other thing that I was concerned about up front, and this may not be valid, is that theoretically, from a chemistry standpoint, methylcobalamin can methylate mercury. And if the person has inorganic mercury in their body that they converted from mercury vapor from their amalgams, and you give them a lot of methylcobalamin, you might convert, methylcobalamin, you might make methylmercury and move it into their brain. Okay, so I was cautious about that. But other people said, no, that doesn't happen. I don't know. Maybe there's some opinions here.
Do you have any information on vitamin D3? Vitamin D, David?
No, I don't have any more than other people do, but it's good stuff, and especially if you live in Sweden, where the sun doesn't shine all that much in the winter.
Even in Boston.
Yeah, well, sure. And I was low, too. I'm taking 5,000 IUs a day myself, and I live in California.
But Stephanie Seneff at MIT discussed this some weeks ago, and she said that D3 have to be methylated, and you get that in sunshine.
Ah, uh-huh.
not by taking the D3.
But not by taking it. That's very interesting.
Yeah, very interesting because it's not settled yet what type of D3 you should have.
Well, maybe,
Sunshine gives the methylated.
well, maybe that explains why there are people taking high doses of D3 and then they get their vitamin D tested and it hasn't come up, you know? That could be the answer to that. My brother had that problem. He's taking 10,000 now, I think. But he needs to get outside a little more, you know, get some sunshine. Let's see here. Oh, yeah.
Some advantage in taking B12 in the form of injections instead of oral?
Yeah, you can do that, and it's better. I mean, you get more into the blood that way. The reason I use sublingual is because a lot of the people I deal with can't go to a doctor, they can't find a doctor, they can't find a doctor who will do that, you know, whatever. So, you know, that's what we do.
Yeah, I have a question. First of all, I just want to say something about the Swedish social security system. Because if you get money for your daily provides and you don't have any money, then you cannot use it for treatment. And if you want to have this type of treatment, you probably have to appeal all the way up to Supreme Court to get it. And then when the Swedish FDA finds out, they will revoke the doctor's license. So that's how the sun shines in Sweden.
You need to have a rich uncle that will finance it for you, huh?
What I was going to ask you about is this study. I mean, it has a limited clinical value because it was not an RCT.
Mm-hmm.
But I want to ask you, this you had for the first and foremost symptom you had was migraine. There are two types of migraine that differs as much as a train and a car. They are very different. Did you make any differentiation between those types?
No, Dr. Nathan is the guy who dealt with the patients. I don't know what I can't tell you, yeah.
Believe that. Do you have any, because when you club it together as one pain reduction, do you have what type of pain, if it's musculoskeletal or if it's other types?
No.
No differentiation.
No. There are a whole lot of things that should have been done better, you know.
I mean, I'm not saying it's an interesting study, but it's pretty much worthless.
Oh, I know. Yeah, I was just hoping. I was hoping the study would interest somebody who could really do a good study. See, and that might happen still. It might happen.
And then coming to my last point, because you had said that one patient dropped out and went to Mayo, and that's as far as I know, they are pretty open-minded, and didn't they pick up on this?
Well, I guess this is being recorded, right? So I have to be careful what I say. I'll just tell you that over the past 15 years, I've been on the patient internet groups for chronic fatigue syndrome, and I've heard from a lot of people, and some of them have gone to Mayo. And the report pretty much from everyone is that Mayo runs a whole lot of wonderful tests. They send you to various specialists, and they all say, it's normal. What you need to do is see our psychiatrist. And they send them over there and prescribe an antidepressant, okay? And that's what Mayo does for chronic fatigue syndrome, and I think that's still true.
But how did they get this state-of-the-art track?
How do they what?
They have a reputation. They state-of-the-art.
Well, Mayo is very good if you have a well-known conventional medical problem. They are state-of-the-art for dealing with things that are well-known and understood and agreed upon, okay? But when you have something that's not in the book, what they do is send you through the specialists. And if they can't find anything in those specialties, they send you to the shrink, okay? That's what happens.
The same with hypothyroidism. The same with hypothyroidism.
Uh-huh.
They measure TSH and send them to the psychiatrist.
Yeah. I mean, I think this is true. I'm not saying bad things about them. This is a fact. This is what I've heard and from quite a few people.
It's an insufficiency to explain the clinical symptoms. You have to analyze the clinical situation.
Yeah. The difficulty is there's specialization, and each one of the specialists stays within his box, and there's nobody that spans all of them and looks at the big picture.
You need a holistic view.
Yeah, exactly.
Regarding the epidemic at the Royal Free Hospital, which started it all, I have a booklet from the British health authorities about the epidemic, and the one thing they didn't measure was what was in the air. because there are several studies, or at least a few of them, in other places, for instance in a factory in Kentucky where they painted the ventilation system with a mercury-containing paint, and they started an epidemic of chronic fatigue syndrome and other diagnoses. And it also spread to people at home because they carried it home in clothes and breathed it out and so on. And Ulrika and I heard about a hospital in Canada where they painted the ventilation system as well. And when they switched on the heat, it caused an epidemic of most of the staff got sick in all kinds of these diagnoses. Chronic fatigue syndrome, fibromyalgia, electrosensitivity, and so on, depending on the sensitivity of the patient.
This reminds me of Legionnaire's disease. You know about Legionnaire's disease? That was something that came in the air conditioning system also. Yeah. Okay, well, I want to just mention the acknowledgments here. I have a lot of them because I depended on a lot of people for this. Paul Cheney and Patricia Salvato and Derek Inlander, they're MDs, and they used glutathione in treating ME/CFS early on. They were some of the first ones to do that. Les Simpson and Paul Cheney and Charlie Lapp pioneered use of high-dose B12. And Dr. Reglin's work showed the importance of folate, but I didn't recognize it at the time, but it did. These guys, this guy's in Southern California, and Professor Hooper's in the UK, they noted early on that there's a connection between autism and ME/CFS. And I always thought that was interesting. They were both saying, I think there's a connection. They were saying this publicly. Bernie Rimlin, who's no longer living, he founded the DAN Project for studying autism, and I knew Bernie, the wonderful fellow. Jill James, as I mentioned, was the one who found that lifting the methylation block caused glutathione to come up in autism. Dick Deeth put out a hypothesis about methylation in autism, and it looks a lot like the one I have for chronic fatigue syndrome. I've used initials for the patients for their privacy, okay, but I want to acknowledge them. And this lady, this lady was the first one to try the DAN treatment. Before I got to YASCO, I was telling them, use the DAN treatment. So she tried it and got some benefit out of it. And then I learned about Amy Yasko, and she had done all this work on methylation-related disorders. So I said, okay, try the Yasko treatment. So this lady here was the first one to do that, and she had benefit. And so then David Bell, who's retired now, he's writing books, but he doesn't practice. He was present at one of the original epidemics of chronic fatigue syndrome. It was in children in upstate New York. And he's written a couple of books in the past. He's still writing another one. But he said to me, okay, I think your theory is correct. Give me a treatment, okay? So this was kind of a challenge for me because I wasn't used to treating. I was trying to work out theory, you know? So that's when I went and extracted something from Amy Yasko, and I sent it to him. I said, okay, here's a treatment. And I also put it on the internet. And so then this woman helped me to formulate that treatment. She was on the full Yasko program. That woman was the first one to try the simplified treatment, and she had remarkable results up front. She posted it to the internet group, and it just was like wildfire. And I was trying to keep track of all the people doing it. I got up to 60 people in a very short time, and then I lost count of all of them, you know, because as soon as somebody has good results, they go for it, you know. So, but then, you know, a few months into this, we started getting adverse effects from some of the people, and that was not fun. And it turned out, and this is why I insist, you know, somebody on this treatment, I put the first view graph up, or the first slide, needs to be monitored by a physician, because there were people who picked this up off the internet who had all kinds of comorbidities. They didn't just have chronic fatigue syndrome. There was a woman with a history of autoimmune disorders. She had lupus. She had multiple connective tissue disorders. She had, Sjogren's disease. She had all this stuff. And when she started this treatment, it activated her immune system, and her autoimmune diseases got worse, okay? And she got this problem in her eye, and her sclerosis. And she had to have steroid drops put in her eye, and that calmed things down. But that was one case. There were 2 women who got constipated for 12 days, okay? That was kind of worrisome. There was one woman who had pain in her chest, and so she went in and there was no heart attack, but, we wondered. There was one woman who had a multinodular goiter. She had a history of that, had part of it removed. When she did this, it caused her thyroid to get larger and pinched her windpipe. She couldn't breathe very well, okay? She went to the ER, and eventually she had surgery and had the rest of her thyroid removed. So the point is that you can't just do this at home, You need to have a physician who knows the case and who can say, okay, well, let's watch and see what happens. Let's take it easy, So anyway, we learned a lot from those things. Fortunately, nobody died. I was very happy about that. And most of those people are still on the treatment. They didn't want to quit, okay, because they had benefits in addition to these problems. And so as soon as they could resolve some of those things, they came back and started doing it again. So I said, well, just make sure your doctor is watching you, And then Tapan Audia, he's the one who developed the methylation pathways panel. He works for Health Diagnostics and Research Institute. Tapan is a very bright guy. He's from India. He worked with Hans Krebs at Oxford, okay? So he really learned his biochemistry, and he really is very helpful. And then on the clinical study that we did, that was supported by an anonymous donor as part of what we call the Rotnaling Working Group. And it was conducted by Dr. Nathan, as I mentioned. We had help from Tapan Audia, Amy Yasko, Jacob Teitelbaum, and Richie Shoemaker with planning the study. And then the management was supported by the staff in his office, Kevin Joyce and Neva Dick. So those were the people. I think that's it. Yeah, that's just a folate thing there, in case somebody wants to know the full folate metabolism. There it is. You want to hear about it, is that right? Oh, okay, let's say, hey, let's stay for another hour. What do you say?
So you say that nobody died and nobody nearly got killed, so you can say the main conclusion from the whole study that it's far more safer to do the study with Paul Cheney than go hunting with his brother Dick.
Yeah, well, that's true. He didn't kill the guy either, but it wasn't good, right? Yeah. I don't know if they're related, but anyway, they have the same name, yeah. Are there any other comments or questions or anything? I guess are we over time here? Are we supposed to stop at 5 or? Oh, okay, we're still okay, okay. Anybody else want to raise an issue?
I just wanted to say about methylcobalamin and amalgam patients. As I said to you, I work with amalgam patients and electrosensitive patients, and I estimate that about 50% of my patients have good, it's good for them, they feel good with this.
The methylcobalamin is good for them?
Yeah. So, and when you work with sensitive patients, there are always patients that don't stand this or that medication.
Right.
One, but you talked about that the brain should
Yeah.
take up more mercury. I haven't got that impression.
Okay, okay. Well, there's one paper in the literature in guinea pigs, not humans, but guinea pigs, and they did observe, methylation of mercury from using methylcobalamin, but did that happen in the metabolism of the guinea pig, or was it caused by bacteria in the guinea pig gut? I don't know. So I don't know. I've just been cautious about that. But there were two women before we started all this on the internet group who got big injections of methylcobalamin, not related to our study or anything. They were just doing B12, you know, so they got pretty big injections of that, and it was, you know, several milligrams, and both of them reported some neurological symptoms right away, and so that's what concerned me. They both had mercury, pretty high mercury level, so that's why I got a little bit cautious about that, because theoretically, you know, in the test tube, you can react methylcobalamin with mercury and make methylmercury. That reaction will go. It's one of the only things that will give a methyl group to mercury because of the charge. You know, the mercury is a +2 mercuric ion, inorganic mercury, and you have to have a minus in order to attract that. And the only thing that will give you a negative methyl group is cobalamin. So.
The patient used to say that they got less tired and more concentrated and better memory.
Okay. Yeah.
I don't think that that the guinea pigs have any amalgam fillings, and therefore some of these research is almost nothing worth. But I think I have just written a book from the dental assistants, and many of the women have worked in dental clinics, and I think they were not asked about what they was working with, your women there. We have about 500 known women in Sweden, and more than 1,200 in Norway and in Denmark, and I see them all over the world. And they have worked with mercury in a way that is very, very different, problematic.
And do you use methylcobalamin with those people?
Yes, we have got, the most of us have been treated with methylcobalamin and folsyra, and it is the only thing that we are getting better of.
Okay.
With selenium and vitamins.
And what kind of a dosage of methylcobalamin do you use?
Ulrika, det vet du.
Also in Sweden you can get injections with methylcobalamin 10 milligrams for injection.
And that's what you use? Some numbers like that?
Yeah.
Okay, all right.
I don't know if you have seen the study by Regland when he measured blood levels of B12 compared to CSF levels of the vitamin, and they might have completely normal levels in blood and pathological low levels in cerebrospinal fluid.
That's right, yeah, and the homocysteine was high in the spinal fluid, yeah.
Now, I think that protandim should be tried here, because that stimulates most antioxidant enzymes that are natural in the body. And it decreases protandim.
PROTANDIM. Yeah.
Protandim, and it's produced by a company called Life Vantage. And
it's herbal, right? It's an herbal combination.
No, it's a combination of Ayurvedic stuff, silimarine, green tea, ashwagandha, and curcumin and buka. They are all ashwagandha, all
Ayurvedic treatments.
Stuff. And the combination of these were increasing SOD and catalase 18 times more than any of the individual ingredients. So they got a patent on it, a use patent for that reason.
Yeah.
And about 8 papers published related to this. Besides of increasing the antioxidant enzyme, it decreases inflammation and fibrous formation. So that could save glutathione.
Yeah.
And it might even stimulate glutathione. That probably is known. We have to ask them.
Yeah. Yeah, okay, that's something to think about.
Google and you get it.
Och vad är det mer än silmarin?
Silimarin, ashwagandha, green tea, curcumin, and something called buka and silimarin. No. men de skriver alltså curcumarin is known to affect NF-kappa B, which is the nuclear factor kappa B which introduce inflammation. So it's an important, that's why probably Indians are less inflamed than others.
Mhm.
These had been, until they start to eat masola now, where they will increase again. Omega-6 is something else to regard here,
Mm-hmm.
because many Americans eat too much omega-6.
Yeah.
And they get it also from meat, because the cows are eating
Yeah.
corn.
Yeah. That's right.
Cows should eat grass.
That's right. Exactly. Yeah. Yeah. There's not as much money in that, though. You know, the old money factor comes in again. You know.
Yeah.
Any other comments, or should we close down here?
I think you mentioned about vitamins, how they act like domino. What is it? Can you say domino bricks? If one doesn't work, the rest is.
The antioxidants. Yeah, the antioxidants are in a network, and they work together. Professor Lester Packer studied that at UC Berkeley, and he wrote a book. He wrote a book called The Antioxidant Miracle, which is a crazy title, but it's a good book. And he talks about glutathione, vitamin C, alpha lipoic acid, vitamin E, and coenzyme Q10. Those are in what he calls the antioxidant network, and they support each other. And then the other antioxidants are outside the network, and they're sort of once through that they don't get regenerated, but they take out free radicals on their way through, you know. So.
And there is very important the Q10, because in America now the heart insufficiency is increasing very much with the statin treatments.
Mm-hmm. Mm-hmm.
It's not really known yet, but because it's such a strong influence on increasing the statin treatment. The drug companies, of course, earn much money on it, so it's no way to stop them at the moment.
Yeah, it's unfortunate. Unfortunate. I understand that one of the drug companies that came out with a statin drug also patented the combination of the statin drug with CoQ10, but they don't produce it.
Yes,
Okay, so no one else can produce it either. See, that's very interesting.
Merck has a patent from 1986.
Yeah, that's very interesting. You have to wonder why, right?
They knew that the problem was because
Sure.
they stopped Q10. But since some people don't understand what Q10 is doing.
Yeah. Well, anyway.
You said you had no glutathione in your supplements, but I saw you had broccoli, and that's a lot of glutathione in broccoli. It was included in your supplement.
Yeah. Amy Yasko put that in there, and I guess, it supplies some sulfur compounds, and I guess it supports the sulfur metabolism. I don't know exactly, some people use broccoli for, some of the female treatments. What are they again? Maybe somebody else remembers, but broccoli, it has some things in it that are helpful.
Yeah, it has glutathione. I think it's the most glutathione.
Okay, it supplies its own glutathione. Okay. Yeah, okay.
But when you get broccoli, mostly the stalk. Does that contain this too, or is it just the green stuff?
What did you say?
Well, broccoli sprouts are the most rich in these things, I think.
Yeah,
Broccoli
but most of
sprouts.
it is the stalk. Is it also in the stalk?
I don't know enough about that to comment. Yes.
Did you mention garlic?
Yeah, garlic is in that multivitamin also. Yeah, it was in there. And again, it supplies some sulfur compounds, and I think it has some antioxidant action.
Yeah, could you tell why you need to when you fry your olive oil, which is not partly dangerous, you have to take the dangerous situation from the olive oil with what?
Well, yeah, if you cook with olive oil, it's a good idea to add garlic because that protects the olive oil from oxidizing. And so in Mediterranean cooking, they do that a lot, and then it helps flavor, but what they're really doing is keeping it from oxidizing,
We lobbied the State Bacteriological Laboratorium from the beginning of the 1980s to get them to take out the mercury from the children vaccines. And first it was harmless, and then it was difficult to take it away, and then they took it away. And Sweden has only a small fraction of the autism cases compared to the United States.
It really helped, huh? Yeah.
This is increasing, isn't it?
Ja, det är ju läkemedelsföretagen jobbar ju på för att få ut sina mediciner, så statistiken är osäker.
All right.
Yes.
What kind of source do you use to produce B12?
What about producing B12?
What kind of source?
Oh, source. Where do you get it? Well, again, we order it usually from Amy Yasko. In the most recent version of the protocol I'm using, we're using her drops. They're liquid drops, and you put them under the tongue. She calls that Methylmate B, and she sells that. But before that, we were using a Perk product, which was also under the tongue, and it was hydroxycobalamin. They were both hydroxycobalamin. Some people use methylcobalamin. She makes the drops for methyl. She makes adenozylcobalamin drops. She makes all of these. So some people try a little bit of each one, you know. From where? HolisticHeal.com on the internet. Where does she get it? Oh, the original source. I don't know that. I do know that she's got a guy on the staff who used to be head of the Alternative Medicine Society or something like that, and he supposedly really knows his supplements, and he's checking out the sources and making sure it's safe and all of that. So, but I don't know the answer.
I know the colibacterias are producing it.
Who's producing it?
E. coli. Colibacterias.
Oh, bacteria in it. Oh. Yeah, these days you have to wonder about the stuff that's coming from China and all that too, you know. Okay, well, I guess we'll turn it over to the chairwoman.
We will have time tomorrow also to ask questions to you.
Okay, yeah.